Thank you, Tracy. Highly appreciated for joining us today. May I now make a start for the next session, which is called COVID-19 Pandemic and Future of Bariatrics. I have the privilege to introduce the 4 chairs for the session: Mr. Chandra Cheruvu, Mr. William Hawkins, Mr. David Kerrigan, and Mr. John Loy here. I would leave the rest of the session in their hands. Thank you.
Thank you, Sanjay. First of all, a huge congratulations to Sanjay for organizing such a fantastic program with international faculty. Looking at the large number of registration reflects the quality of the program organized by Sanjay. Well done, Sanjay. Now, it's a pleasure to join my co-chairman, Mr. Will Hawkins, Mr. John Loy, and Mr. David Kerrigan, all colleagues who we worked together in the past. And we have a fantastic program here. The first speaker of the day, I'll start without much ado, is Mr. Vinod Menon. Mr. Vinod Menon is a consultant upper GI, a bariatric surgeon at the University Hospital, Coventry for nearly 20 years. He has been exemplary. He set up an exemplary unit of developing initially the esophageal cancer surgery, subsequently developed the bariatric surgery, which has become one of the biggest centers in the country. Mr. Menon, apart from his busy clinical work, he's been instrumental in supporting BOMS for almost a decade, initially being a treasurer, then the secretary, now being elected as the president or the current president of the British Obesity and Metabolic Surgical Society. He's not only a good surgeon, but is recognized for his good leadership skills by leading the training unit, the hands-on skill unit in Coventry at the University Hospital. So I would welcome Vinod Menon to speak about this, the specialist topic about the vision of UK bariatric surgery. Welcome, Vinod.
Thank you, Chandra. Can you hear me, Chandra?
Yes, thank you.
So good morning, chairpersons, colleagues, ladies and gentlemen, and thank you for the very warm introduction, Chandra. Good morning to all of you, and warm greetings from BOMS, the British Obesity and Metabolic Surgery Society. And huge congratulations to my friend and colleague, Mr. Sanjay Agrawal, for organizing this great meeting. And it's a pleasure and privilege to be here today to be able to talk about the vision for UK bariatric surgery. I'm just trying to share my slides. Let me just do that now. Is that coming on, Chandra? Thank you. Yeah, lovely. So this is indeed the vision of BOMS, the vision of British Obesity and Metabolic Surgery Society. Currently, bariatric metabolic operations are only available for 0.25% of the eligible population. And BOMS proposes to raise this to 20,000 per year, reaching 1% of the eligible patients within 3 years. And this is by ensuring safe surgery, adequate infrastructure, providing the required manpower and ensuring training, and developing strong multidisciplinary teams. So the success of this vision, therefore, rests on 3 factors. We have to be able to articulate this vision very clearly, develop a very clear strategy, and to be able to continuously monitor our performance. So the BOMS briefing paper that was published last year clearly articulates this vision. The UK population is 68 million, of which 52 million are adults, 32 million have got high BMI, 14 million are clinically obese, 2 million qualify for bariatric surgery as per NICE guidance. We have 46 surgeons, 46 hospitals, 160 surgeons, efficient MDT network. Peter Small is going to talk to us about NBSR, which is indeed the jewel on our crown. The 5,000 operations cost the NHS 30 million. What we're asking for is an additional 90 million to get to 20,000 operations. They have 160 surgeons, so 1 all-day list per surgeon per week times 42 weeks will get us to that number. Please remember that the NHS recently allocated £5.6 billion, which is £5,600 million to tackle waiting lists. We are asking for 90 million. And also the general practitioners have been allocated £250 million to do face-to-face appointments. So put that into context. The link between obesity and diabetes is well proven. We all know that around 10 years back, we did about 9,000 operations per year on the NHS, and this has come down to about 5,000. That's been the case. And there have been a few factors that have contributed to this, which I've highlighted here. I think we need to make a little mention about COVID-19, and the part on the left shows where we are, about 10 million people affected, almost 150,000 people have lost their lives. We still got close between 40 and 50,000 new cases a day, with 150 deaths per day. That's really significant, 18 months into the pandemic. But the positive note is the one on the slide, right, which gives a real ray of hope about the level of vaccination. Particularly, a quarter of our population have had their booster dose. We saw an absolute stoppage of all elective work, including bariatrics, around mid-March 2020, and it remained that way for a number of months. BOMs were very proactive. We did this open letter to the Prime Minister at the end of May last year, demanding urgent restoration of weight loss surgery, particularly in the light of COVID. We produced the Safe Bariatric Surgery guidance at the end of May, which was the initial part of developing this vision. We were continuing to work very strongly and very actively with the all-party parliamentary group on obesity, which have recognized the following policies for inclusion in any comprehensive strategy on obesity, and you can see access to surgery clearly highlighted there. 2021 was a landmark year for BOMs, where we reinvented ourselves, relaunched ourselves as the UK's internationally recognized Bariatric Surgery Society, keeping us in line with all the other international societies. We developed our own charitable incorporated organization, and we have fantastic secretarial support through Executive Business Solutions through Gail and Fran. We would not have been able to embark on this journey and our vision without the support of our corporate partners. And I particularly want to highlight Johnson & Johnson, Medtronic, Novo Nordisk, and Go, who share the vision with us and are part and parcel, standing shoulder to shoulder with us. And very soon, I would love to see one more partner joining this rank. On council, BOMS Council is really rich, and I'm really fortunate to be surrounded by fantastic colleagues, men and women, who have put their heart and soul into fulfilling this vision. We've got a new political ambassador in the form of Professor David Kerrigan, is working with Westminster and with the political side, supported by J&J and Medtronic. Rachel Batteram's been an absolute star. She's been working with the DOH, NHS England, Royal College of Physicians, and we are optimistic of securing a multi-year, multi-million-pound settlement from next financial year, which will really propel us to achieving this vision. Peter Small and team, the NBSR, indeed the jewel on the crown. Peter's going to follow me on, so I wouldn't steal his thunder. As a society, we are committed to equality, inclusivity, and diversity. Jim Byrne, our treasurer, has got a real passion for this, and is interacting on a very personal note with Neil Mortensen, President of the College of Surgeons. For the first time ever, we got a bariatric surgeon at the Council of the College of Surgeons through our treasurer, Ahmed, who is also working hard to get the bariatric bit of the curriculum sorted. The website is an integral part of any society, and very soon we'll be relaunching our new website through Jim Byrne and Cynthia leading on that piece of work. Professional education, Sharif Abad has been absolutely a star. We've set up journal clubs, webinars, and education is very strongly on our agenda. Trainees are the voice of the future, and we need to be able to look after them and mentor them. Roxana Sakari has been a real delightful chair. Now we got trainees, have got a voting seat on council. For the last 2 years, we've offered free membership. We've got more than 100 trainee members. We've got running a series of courses, simulation, cadaveric courses. And as a specialty, bariatric surgery and BOMs have got the highest number of senior clinical fellows awarded by the College of Surgeons. Dimitri Pananis is the first surgical specialty lead in bariatrics, and he's taking the research agenda forward. We've got a very vibrant IHP forum, 50% of our membership IHPs. Sally, Emma, and Helen are leading on this. Kamal's got a real passion towards patient safety, and the number of reports the committee have put out is phenomenal. Annual scientific meetings are an integral part of our society, and I'm delighted to see Chetan Palmer, who led the ASM Scientific Committee, as a chair and had a very successful meeting in Oxford. So we are all in the right place to be achieving this vision and beyond. We've got to set up a fantastic partnership with ALS GBI, where we send representatives to each other's council and we work hand in hand. Lilian Kow and Scott Shikora have been very, very supportive in pursuit of this vision and journey through IFSO. Similarly, Harris Khwaja through the IBC and Sanjay through LIBSS. But what I want to particularly focus on is the recent collaboration we have signed with the Obesity Surgical Society of India, who will be here tomorrow. And we'll be supporting each other's ASMs. We'll be supporting fellows going from India to the UK and from UK to India. And the partnerships just begin across a whole spectrum of things. So we'll be working in very, very close collaboration. Everything's about patients, and it's nothing about them without them. And we work very strongly and closely with the Obesity Empowerment Network through Rachel Batteram. And this again is supporting our vision, because we need to be doing what our patients want us to do. We've really strengthened NBSR, which is monitoring our performance with mandatory data entry, recording inpatient complications, unplanned admission to critical care, immediate reporting of unplanned readmissions, and detailed live recording of follow-up. And Peter will go through that in detail. But again, this is an integral part of our function and our strategy and our vision. We have reports like this, which hit our desks every day at midnight. And this is, we've done more than close to 6,000 cases in the last 15 months. This does not include the data from 5 centers with standalone databases. So what's absolutely key is look at the number of private bariatric operations that's been recorded, which is absolutely integral. So I think there is an engagement, there's an involvement by clinicians involved in care of patients. We work very closely with the IFSO Global Registry, which have got more than 500,000 patients now, and we are second at the top, almost 85,000 cases, and shows our level of integration and alignment of vision with the wider Bariatric Metabolic Society around the world. So having listened to this, to support this vision, what can each and every one of you do? And I would suggest 3 streams. You got to engage with your commissioners and all stakeholders, highlighting the clinical and health economic benefits of this type of surgery. We need to dispel the myth of high complication rates. Show them your data, show them our data. And as leaders, think differently, get inspired and lead your services. So finishing off, I think our vision of reaching up to 20,000 operations per year in the next 3 years, ensuring safety, infrastructure, manpower, training, and outcomes reporting is really feasible, it's really achievable. And we can all do this all together. And I'm reminded by this famous quote from the great American philanthropist, John D. Rockefeller, who said, "The key to success is to do the common tasks uncommonly well." And that is indeed what we are trying to achieve. Thank you for your patient listening.
That's an excellent talk. We'll take the questions at the end. Shall we move on to the next speaker? Is that acceptable? Yeah, thank you. So it's going to be next. Can the next person introduce, please? Chair, please. Thank you.
Yes, that'd be me. I'll introduce Peter. So thank you again to Sanjay for setting this up. It's an honour to be part of this amazing conference. Our next speaker is Peter Small, who has been a consultant upper GI and bariatric surgeon in Sunderland for over 20 years. He's a founder member of what's now one of the biggest and busiest bariatric centres in the UK. And as Vinod has explained, he is the chair of the NBSR. He's going to talk to us about how the UK have approached the COVID pandemic and its impact on bariatric surgery. I'm sure the registry will be an important part of his talk as well. Over to you, Peter.
Thanks very much, Will. Yes, the registry will be an important part, and half of my slides have already been stolen by Vinod. Anyway, if I'm allowed to share screen. Right. How's that, Will? Can you see?
Yeah.
Yeah. Grand. Okay.
Yeah,
well, firstly, thank you very much to the organisers of LIBSS and Sanjay for inviting me to speak to you today. I've been given the title of how the COVID pandemic has affected bariatric surgery in the UK, as it has right across the world. But we have been in the very fortunate position of having the MBSR, has been mentioned already by Vinod, and allowing us to very closely monitor what's been happening over the last year or so. I haven't got any particular conflicts of interest in making this talk. So, as Vinod mentioned, at the end of May last year, we were struggling with the concept of how to restart bariatric surgery safely. And after a bit of banging backwards and forwards, we released this guidance document on the 28th of May. It went onto the old BOMS website. In addition to this guidance, we were going to produce a weekly MBSR report to BOMS members so they could actually start bariatric surgery knowing they weren't isolated or out on a limb and that everybody else was doing it. In addition, the executive members of BOMS had access to a daily report on the number of cases that were being done. And clearly our aim was to demonstrate the safe restart of bariatric surgery, mainly in England, but in the UK as a whole. There were a number of statements that were made in that, and one was to mandate that surgical teams entered their patient data into the registry basically in near real time, and we suggest within 48 hours of surgery or the discharge of a case. It was also going to be very helpful if we could get NHS number, which is a constant battle we currently have, not only with the HRA, but also with some units. And details of the index procedure. We were looking for inpatient complications, unplanned admissions to critical care as a sort of measure of a complication that might have happened, particularly given that COVID and obesity usually ended up with the patients being admitted to intensive care for respiratory support. And if there were any other severe unexpected events, those were to be reported. One of the problems we have with the registry is that if a patient gets readmitted after an operation, we don't always get told it. So we emphasize the need to report unplanned readmissions. The follow-up of patients was also important. If they had a problem develop at home, which the surgeon was unaware of, one would hope that that would have been picked up at the 6-week follow-up. So it was quite a detailed list of things that we were hoping to achieve. And given that this is a voluntary registry, or started off as that, really quite a big ask, but it worked. Funnily enough, Vinod chose the same day to do a slide cut of the report that is still coming out. And on the 21st of November, which is less than a week ago, over 5,500 procedures had been done since the 1st of June, which is when bariatric surgery really restarted. And I draw your attention to the unplanned ITU admissions. And we know that there's very, very few unplanned admissions have occurred in that large number of procedures. And some have not yet been recorded, but 5,000 or thereabouts out of 5,500 weren't admitted to ITU. We know that. So that is excellent. There was one death early on in an ASA 4 patient, which was unfortunate, but was going to happen anyway. And I think if we look at the figures, 1 in 5,500 in hospital deaths. I think we really should be congratulated on that. That has to be a safe restart. We haven't had any COVID alerts returned to us. There may well be. I find it hard to believe that 5,500 patients, there hasn't been a single COVID infection, but it hasn't resulted in anything serious that's come back to us. Again, as Vinod mentioned, there are 5 units with their own standalone databases, which are not included in this live report. Sunderland being one of them, but there's North Tyneside, Imperial St Mary's in London, Taunton and Stoke, North Staffordshire. For the BOMS meeting that we had in Oxford earlier on this year, I was able to take the registry report towards the end of July and merge those 5 units. So this was the report that came out on the 26th of July, where it was just under 4,000 cases. Again, you can see there's that death that was there. There were very low numbers of ITU unplanned admissions. And when we pulled together the standalone databases with this, there was about 500 odd cases missing. So not an insignificant number. There was an extra unplanned admission and another death, I'm afraid, which was also probably unavoidable. But even so, 2 deaths out of 4,500 patients, 1 in 2,000. Those are better figures than have been reported in the NBSR reports to date. So again, emphasizing the really safe restart of bariatric surgery. The talk really is looking at how COVID has affected bariatric surgery. And we are due to publish a clinical outcomes publication next month for bariatric surgery in England. So we have actually pulled together and have started analysing this data, and I can give you some heads up figures. The report is looking at operations that have been put into the registry since 2016 up to March of this year. And there's been just under 30,000 procedures performed in that time. The vast majority being in the NHS of just under 21,000, but there are 8,500 private cases in that. Now, there are a number of cases that haven't been classified as NHS or private, and this is historic. I'm really just highlighting that this period actually covers the relaunch or the launch of version 2 of the NBSR, where we did some additional operations were put in and encouragement given to many to ensure that they recorded their data. So bear this in mind, that version 2 started somewhere around about 2017, 2018. And here are the total number of bariatric procedures recorded in the registry over that period by year. Now these are financial years. So you can see that we're running around 8,000 procedures by year. Now we've talked about 5,000 or 6,000 per year. The difference being the private sector. The private sector is not reported in the COP. It's the NHS figures that are given. But look at this drop. Remember, this is financial year, so we're talking about April 2020 to March 21, basically the restart of bariatric surgery. And we've gone from almost 8,000 to under 3,000 procedures. So bariatric surgery, as it is, has taken a massive, massive hit with the stopping of elective surgery. And we're able to break these down now by NHS and private sector. Now, again, you can see, as I mentioned, about 6,000 in the NHS, 2,000 in the private sector. But what I do find very interesting is that the difference in 2021 compared with previous years is the number of private cases versus the NHS. Now, does this mean that more cases have been done in the private sector, or does it mean that the private sector are starting to enter their cases into the NBSR to prove that they're being safe? It's a fascinating finding, and I hope it's one that continues. That as we get back to more normal practice, we'll find that we're recording far more of the private cases than we used to. When we break it down by the type of procedures, so here we're talking about primary cases. So this is the patient that comes to you for their first operation. You can see that's what's been hit. 5,000 primary cases in NHS, just over 1,000. Private sector has seen a little bit of a fall, but not as much as we've seen on the NHS side. And that really has to be because private hospitals were kept COVID free and have probably been able to do more cases safely. This is reflected across all types of surgery. So if you're doing planned secondary surgery, so you'll be thinking about somebody who maybe is having a sleeve, which is then converted to a DS. These numbers have taken a dramatic hit, both private and NHS. If we look at revisional surgery, again, taking a massive hit. Now, revisional surgery, not doing these, maybe we've been thinking that those are more at risk of having something done. I'm not sure, but again, as I say, taking a massive hit. This I found quite interesting, the number of balloon procedures. Now, bear in mind that private cases weren't in as much here as they were, but there is a significant number of balloons being put in privately. And COVID, could this possibly be patients realizing they've got to get their weight down because they want to reduce the risks of any problems from COVID? Who knows? Speculation, but an interesting difference between NHS and private. There are a number of patients where we haven't got the type of surgery specified. And as I mentioned earlier, 1718 is when we introduced version 2 of the registry. So this might actually represent one anastomosis because it wasn't a procedure that was recorded in the registry directly. But the important thing to take from this slide is that we are now specifying very clearly what type of procedures are being done, which suggests that the registry itself is much more user-friendly. I'm not saying it's perfect. We do want a version 3, and that will come with the recording of complications. Is there any light at the end of the tunnel? Well, if we look at the report after a year, so 1st of June 2020 to 1st of June 21, 3,000 cases done. Pretty 50-50 NHS private. Remember that the standalone units are missing from this, but there's pretty 50-50. So we've got about 3,000 up to the beginning of June. If you look at the 21st of November, there's 5,500. So in the intervening years, we've more than doubled the number of cases, intervening months, we've doubled the number of cases that have been done. So that really equates to somewhere around about 400 or 500 cases being done per month since April, which might mean that if we get to the end of the financial year and still being allowed to do bariatrics, somewhere around about 6,000 cases in this financial year. But remember, winter is here, so we're about to hit the winter bed pressures. In summary, COVID restrictions have caused a significant reduction in the number of bariatric surgeries done in the UK. Units are trying to catch up, but just be aware there are further problems just around the corner. Don't forget that we've had blocks in referrals, we've had blocks in seeing patients to get them onto waiting lists, and we're about to hit the hospital winter pressures. Thank you very much for listening to me. As Chandra said, we'll take the questions towards the end. I hope you found that interesting.
Thank you, Peter. It's a fantastic talk.
Thank you, Peter.
Good insight to the whole thing. Could I request Mr. Kerrigan to introduce Rishi Singhal, please? Thank you.
So before introducing Rishi, just again, a great congratulations to Sanjay and his team for the immense amount of hard work they've done to put together this meeting and make it run so smoothly. So congratulations. It's a pleasure to introduce Rishi Singhal, who's probably known to most of you. He's a consultant surgeon and senior lecturer at the University of Birmingham, East and the Heart of England NHS Trust. He's a prolific researcher across a wide range of topics relevant to bariatric surgery, but perhaps, you know, best known in these days of the pandemic for the excellent work he's done with the Geneva study, which was looking at 30-day outcomes globally for during the pandemic. And I'm sure Rishi's going to tell us all about that now. So over to you, Rishi.
Thank you, David, and thank you to Sanjay for organizing such a nice meeting with a brilliant program. It is quite surreal to see that we are still meeting the same way that we were meeting last year, and it's been 18 months that we've been in this pandemic. But I think Bariatric Society overall has done very well as a whole, and that's what we are here to find out. How did we manage in the last 18 months? You can all see my slides. Okay, so I have no disclosures. This is my case mix slide, and whilst I put my case mix slide here, I just want to remind us that although we all have lived through the pandemic for the last 18 months, there are many details about this pandemic that we are now fuzzy about. So my first few slides will try reminding you about what happened in the beginning of the pandemic and how did research evolve during the beginning of the pandemic to what we are today. So on the 14th of March, the WHO declared what is happening right now as a pandemic on the 11th of March. IFSO was very quick in recognizing that there was a problem, and within a month of this being declared as a pandemic, IFSO came out with their recommendations with regards to bariatric surgery, which included both bariatric surgery and endoscopic bariatric cases. The advice was that we should try limiting any kind of bariatric surgery for now till we know the full extent of the pandemic and the effect on bariatric procedures. Just 6 days later, Ali Aminian, along with Mohammad Karman Sarawi, published their first manuscript. And this was the first manuscript about any kind of bariatric surgery happening during the pandemic and the outcomes of patients who were infected. In this paper, they presented outcomes of 4 patients who had been infected with COVID, and all of the patients survived. And a month later, we had the very substantial publication by the COVID Surge Group, which was this. So this is where our knowledge of the pandemic and the effect of patients getting infected really started. Now, this was the first and till date the largest study in general surgical patients. This study looked at 1,100 operations approximately performed between the 1st of January and 31st of March, so the first 3 months of 2020. So we must congratulate the COVID Surge team that they were very quick in identifying that there's a problem and running a global collaborative project to collect this data. 1/4 of the patients had elective surgery, and in these patients, 1/4 had infection with SARS-CoV-2 established preoperatively, remainder had postoperative establishment of infections. Now, what is interesting to note that in patients who were infected or who had COVID-19, 51%, so almost half of these patients developed pulmonary complications. And in these patients, the 30-day mortality was up to 38%. Now, this was quite scary statistics when we actually read it, that almost 1 in 2 patients who get infected whilst having surgery or who get operated if they've had an infection already, 1 in 2 patients are expected to die. And this was quite a scary prospect for doing any kind of operation. During this time, my colleagues, along with Kamal Mahavar, who Kamal and I were almost discussing on a daily basis what we should do when the WHO declared this pandemic. And one day after IFSO came up with their guidelines for bariatric surgery, we started our planning and approval process. So the planning and approval process for the Geneva study started on the 15th of April, and we launched this study on the 1st of May. This was a global study, a collaborative project, whereby surgeons from all over the world were submitting data on bariatric procedures performed, which included primary bariatric procedures, revisional bariatric procedures, and any emergency procedures related to bariatric surgery that were performed, such as internal hernia, etc. We collected data on patient demographics, what kind of operations were performed, and the in-hospital and 30-day mortality and morbidity. Now, this study was initially split into 3 parts. The Geneva 1 study, which only looked at the adult data for patients having bariatric surgery up till the 10th of July. The Geneva 2 study, where all adult data until the 31st of October was analyzed, and the Geneva adolescent study. The primary outcome of the study was very well defined, and there were 2 primary outcomes. The first one was the 30-day surgical outcomes, and we measured the surgical outcomes by using the Clavien-Dindo scale, which all of us know is a well-validated scale for comparing complications. Now, this has been one of the lacks in many publications with bariatric surgery in the past, that they haven't used a validated scoring system to identify or grade complications. Similarly, the COVID outcomes for every patient were also graded using the Clavien-Dindo scoring system, and the highest Clavien-Dindo score for a patient was considered when we were analyzing the data. So this is what we found in Geneva 1. So Geneva 1, to remind you, was looking at only adult patients between the 1st of May and the 10th of July who had primary surgery. Now, there were data on 2001 patients, and what we were quite proud of, and the whole bariatric community should be proud of, was that 94.6% of patients had complete data submission. And data was submitted by 218 surgeons from 35 countries across the world. The Geneva 2 was even larger. We had complete data on just under 8,000 patients. That is 99.6% data completion rate. And those of you who have reviewed the data would know that there is no such global collaborative study which has a data completion rate of almost 99.6%. That means that 99.6% patients had a 30-day outcome and a COVID outcome listed with all data points correctly identified in the data. And this data was submitted by 500 surgeons from 185 centers across 42 countries in the world. And if you look at the map of Europe, you can see how many centers actually participated. The participation was wide across West Europe and partly across East Europe, but most large centers in the world participated in the Geneva 2 study. So now to the juicy part, what did we find? Well, the Geneva study was interesting, and these are the outcomes from the overall study, the Geneva 2 study. It was interesting because it was the first study that identified categorically that sleeve is now the predominant operation across the world. More than 50% of primary procedures performed across the world were laparoscopic sleeve gastrectomy. But what was even more surprising, that the one anastomosis gastric bypass had taken the third spot at 10% of overall operations. Revisional and emergency surgery, of course, were small numbers, as you can expect. But when you look at the data, and this is where I'm going to spend some time understanding the differences in the choice of procedures across the world. Now, if you first look at the laparoscopic sleeve gastrectomy, if you look at the fourth row down, with regards to any comorbidity, only 63% patients had any comorbidity. And compare this to RYGB, almost 10% higher at 74%, and OAGB at 80%. So 80% of OAGB patients had a comorbidity as compared to only 63% of sleeve patients. Now, if you look at insulin dependence, and that is the eighth row down, only 2% of the sleeve patients had insulin-dependent diabetes as compared to 5% for Roux-en-Y and 7% for one anastomosis gastric bypass. Similarly, for hypertension, only 27% of the patients had hypertension who had a sleeve gastrectomy as compared to 34% for Roux-en-Y gastric bypass and 39% for one anastomosis gastric bypass. And similar numbers are seen for usage of CPAP. So overall, we found that the cohort having the RYGB or OAGB across the world was a much sicker cohort. Now, interestingly, self-isolation was only advised in 42% of the patients, but we have to remember, this study was performed over 6 months. So self-isolation rates changed from the beginning till the end, and there was a lot of variation. So these are not completely representative of a particular time period, and we'll come to that later. But preoperative testing was performed in at least 80% of the patients, and most of the patients had an RT-PCR. Other investigations included a chest CT scan or a chest X-ray, or sometimes the antibody test. And PPE usage was at around 50%, and we asked for PPE usage for all patients. Now, this is where we start with the results of the study. With regards to 30-day outcomes, 7% of the patients undergoing bariatric surgery developed at least one complication, and this could be clavin window 1 to clavin window 5. But what we are mainly interested in is the serious complications, that is clavin window 3 to 5. And 2.5% of the patients developed a serious complication, and there were 10 deaths. So let's look at the complications in greater detail. Now, let's look at the sleeve column first. If you look at the serious complications and the minor complications, the sleeve was at 3% and 2% as compared to the Roux-en-Y, which was 5%. So almost 1.5 times the minor complications of a sleeve, and more complications than the sleeve with regards to serious complications. OAGB was similar with almost twice the risk of serious complications as compared to sleep. So you see the risk of complications with a Roux-en-Y and OAGB were higher as compared to that of a sleeve, and that almost reflects the complexity of these patients when we look at their comorbidities. So we constructed some regression tables to understand what is exactly happening, what is the difference in patients who have a complication and who do not have a complication. And we looked at various variables like the increase in age, male sex, BMI increase, ethnicity, the type of diabetes, the presence of hypertension, sleep apnea, hypercholesterolemia, or smoking. And what did we find? We found that increasing age, male sex, a history of current or former smoking, insulin-dependent type 2 diabetes versus patients who did not have diabetes, sleep apnea not on CPAP. And this is extremely important. This is the first paper ever to identify that patients with sleep apnea who are not being treated have a much higher risk of complications than patients who do not have sleep apnea. And similarly, hypertension and hypercholesterolemia were independently associated with increased risk of complications on logistic regression analysis. Similarly, emergency revision procedures were high odds and prior experience were important, but all of these things you expect, like age, sex, smoking history, diabetes are important. But sleep apnea, which is not being currently treated, has a higher risk of complications, is never been known before. When we look at the deaths, there were 5 deaths in the sleeve group and 4 in the one anastomosis group. Now that may seem quite high for the one anastomosis group, but let's remember that we are doing much higher risk patients in the one anastomosis group, where the risk of diabetes, hypertension, sleep apnea is much higher. And thus, it is not unexpected the risk of complications is higher. Overall, there were 4 leaks reported, 2 episodes of pulmonary embolism, and 2 COVID pneumonias with PE. With regards to COVID outcomes, only 43 patients developed post-operative symptomatic COVID. We did not screen, this study did not screen for asymptomatic COVID at all. It only looked at symptomatic COVID. And all of these patients had been tested negative preoperatively unless they were emergency bariatric surgery patients or emergency complications for bariatric surgery. Of these 43 patients, 38 had primary BMS, and only 1 of these patients died, which is described in detail at the bottom. This was a 35-year-old female with a BMI of 70, type 2 diabetic, on insulin, hypertensive, sleep apnea, hypercholesterolemia, previous DVT. And she went a one anastomosis gastric bypass. She was negative RT-PCR preoperatively, and this was the only patient who died of symptomatic COVID postoperatively in a study of 8,000 patients. So I must say, and I agree with Peter Small, that the results have been exemplary across the world, and the way the bariatric surgeons have responded to this pandemic has been quite good. Now, this is one of the very interesting analyses that we did as part of Geneva 2. We identified all countries that had a well-defined peak during this period of 6 months, a peak of COVID, and we plotted those peaks. And then we looked at all the patients who developed COVID or were developed symptomatic COVID after surgery in those countries. And what we found that if the country was in the top tertile of their COVID incidence, the risk of post-operative COVID was 0.7% as compared to if the country was in the bottom 2 tertiles. What this means is, if we operate on patients when the country is undergoing a peak, then the risk of them contracting post-operative COVID was much higher than if we operated on patients when the country was not in a COVID peak. Now, it is equally important to understand the outcomes in adolescents. 170 adolescents had been operated during this period. Only 2 of these patients were developed with symptomatic COVID during this time, and the overall complication rates were similar with no mortality. If you look at the case mix for the adolescent group, again, the primary operation was the laparoscopic sleeve gastrectomy with a few Roux-en-Y gastric bypass and 1 anastomosis gastric bypass. Now, all this data, as you know, has been published in the first Geneva 1 was published in Lancet Diabetes and Endocrinology. Geneva 2 was then published in Obesity Surgery. Geneva Adolescent was published in the International Journal of Pediatric Obesity. And the few important points I would like to remind you before I conclude, and this is on to my last 4 slides for conclusion. Some of the other studies have identified that swab testing was beneficial before major surgery, but not before minor surgery. We've also identified that after a positive COVID test, we should wait for at least 4 weeks before doing an operation for a patient. And it's also known that dedicated COVID-19 free pathways are better for safe elective surgery. So in order to conclude, Mr. Chairman, ladies and gentlemen, bariatric metabolic surgery can be safely performed during the pandemic with morbidity and mortality similar to what was seen before the pandemic. The risk of developing symptomatic COVID-19 post-BMS was low, and the local incidence of COVID-19 in the country can affect the incidence of post-bariatric surgery COVID-19. Now, what are the important milestones we achieved in this study? And this is my last slide. For the first time, we've been able to establish an international bariatric collaborative with 537 lead collaborators who are regularly submitting data to this collaborative. We've already published 3 articles. We have 2 articles in press in the International Journal of Obesity and Journal of Bariatric Surgery, and we have 2 further articles that have been submitted and 2 more being written. We're currently conducting the ONWARD study, which looks at outcomes of bariatric surgery in patients with advanced organ failure. So patients with liver failure or cardiac failure or renal failure. And we already have 175 patients with severe failures who had bariatric surgery across the world who have now been enrolled into the study. And the future is for us to use this machinery to collect data on rare indications for minority procedures and conduct multicentric RCTs. Thank you very much.
Well, well done, Rishi. That's excellent talk. And we'll, as you said, save all the questions, which I'm sure there'll be plenty of until the end.
John, can you introduce Professor Lilian Kow next, please? Thank you very much.
Thank you, Chandra. It's a great honor and a privilege to introduce our next speaker. We've heard the UK and the world versions of what's been happening throughout the pandemic in bariatric surgery. It's now my honor to introduce the president of IFSO, Professor Lilian Kow, all the way from Flinders University in Australia. Professor Lilian Kow is a world-leading bariatric surgeon. She jointly introduced the gastric band to Australia. She's been involved in vagal block therapy for bariatric patients, and she will now speak to us about what we can expect over the next decade in bariatric surgery worldwide.
Thank you very much, John. Thank you for the kind invitation to join you all in London. I have a pre-recorded talk, so if someone could play my talk would be great.
Can you get the talk going, please? Chetan? Venkatesh, please.
I've been asked to talk to you about the next decade for bariatric surgery and a view from it. To do so, I'd like to spend a few slides just looking at what happened in the last decade. Now, obesity has been recognized as a chronic progressive disease with exponential growth around the world, such that it has become a global health crisis and could be considered the ongoing pandemic. The metabolic benefits of surgery has been well established with potential cost-effective health benefits. 10 years ago in 2011, in this report on the bariatric surgery worldwide,
It was observed that the most efficacious therapy for morbid obesity is metabolic bariatric surgery. It is effective for type 2 diabetes in the obese population, and yet less than 1% of global obesity is treated by surgery. Also looking at the numbers and the trends, it was observed that sleeve gastrectomy is the operation to scrutinize for its future prevalence and outcomes. In 2013, the same report made the observation that 97% of bariatric surgery performed was laparoscopically with decreased complications, decreased length of hospital stay. There was an increasing number of procedures worldwide, and yet still less than 1% of global obesity is treated by surgery. Sleeve gastrectomy continued to be popular, and over the last 10 years, over 2003 to 2013, its popularity increased from 0 to 30% of total procedures performed worldwide. In 2016, the trend was that the number of procedures increased worldwide. There was a total increase in the number of revisional and endoluminal bariatric metabolic procedures. Of the total, 7% was revisional, 4% endoluminal. And sleeve gastrectomy continued to be the most performed surgical procedure in the world. 2018, there was a slight increase in number of procedures worldwide. The adjustable gastric band over the last 10 years continued to decline in numbers. Sleeve gastrectomy continued to increase its popularity, with the newer operation of one anastomosis gastric bypass becoming popular. If you look at the different trends around the different chapters, in the Latin American chapter, Roux-en-Y gastric bypass is the most common procedure performed. In comparison to the European chapter, Northern American chapter, and the Asia Pacific chapter, sleeve gastrectomy was more commonly performed. Now, we looked at the 6th IFSO Global Registry report, which was released last year. It demonstrates a decrease in numbers over the last 18 months, and this is from the selected high-volume national registries as shown. And this is probably as a result of the COVID-19 pandemic, where the effect of restrictions of elective surgery are shown in this graph. This registry report also looked at the trends in the different operations. If you look at the Roux-en-Y gastric bypass on the left, there has been a decline in the number of procedures performed over the last 10 years. Sleeve gastrectomy on the right graph continues to increase in numbers. In this slide on the left, gastric band continues to decline, while the one anastomosis gastric bypass has an increase in popularity. So what is going to happen in the next decade for bariatric surgery? And it is my personal view that is expressed in the next few slides. Well, firstly, I'm going to talk about numbers. I predict that the numbers will increase. This is what has happened up to now, with an increase but decrease in the last 18 months due to the pandemic. If you look at the trend, that what may have happened had we not had the pandemic, the increase could increase at the same rate as it did prior, and this is my prediction, or that it could increase with exponential growth. I think there will be a slow increase, and then there will be an exponential increase should we conquer this pandemic. What about safety and quality of care? Well, in terms of safety, this particular paper, which was published by the MBSA QUIP data, looking at data from 2008 to 2014 and comparing the data to the mortality for open Roux-en-Y gastric bypass, where the mortality was greater than 1%, there's a significant decrease in mortality for laparoscopic sleeve gastrectomy, 0.1%, and for laparoscopic gastric bypass, 0.2%. So improved patient safety will continue, I believe, over the next decade. What about quality of care? I believe this means comprehensive care, and it is from the quality of the team that provides care to the bariatric patient. So who is the team that will look after this patient? As highlighted in this 2019 update looking at clinical practice guidelines for the perioperative management of the bariatric patient, this is a massive document with unanimous consensus obtained for each of the 85 recommendations, and this paper was endorsed by IFSO. Now, the 85 numbered recommendations were based on the fact that bariatric surgery is a safe and effective intervention. Clinical decision-making should be evidence-based, and a team approach to perioperative care is mandatory. The recommendations, particularly on the multidisciplinary team, is that informed consent is paramount for the patient. And this includes educational materials for the patient. And the patient must understand the experience of the surgeon operating with a specific procedure offered, and that the hospital should have an accredited bariatric surgery program. That's a recommended pre-procedure checklist as well as a peri-operative ERAPS clinical pathway for the comprehensive care. This is an example of the pre-operative checklist, which includes a number of items such as informed consent, informed financial information to the patient, pregnancy, counseling, so on and so forth. This slide shows the ERAPS pathway, which includes standard intraoperative anesthesia pathway with decreased opioid use, fluid management, as well as return to mobilization and oral intake in the post-operative period. Now, what about life expectancy for bariatric surgery? If you look at the SOS, the Swedish Obese Subject Study, this is a recent report looking at the BMI over the duration of up to 20 years of follow-up, looking at surgery compared to controls. And what they found was that with the controls, the change in BMI was small on average over 20 years, but the group that had surgery overall lost most of their weight in the first year, regained a little bit of their weight after 7 to 8 years, and it tends to be stabilized after that up to 20 years. They also look at mortality or the cumulative survival rate and predicted survival based on a model of time to death. And what they found comparing surgery to a control group and a reference population. The median life expectancy was 2.4 years longer in surgery compared to the control group, but less than the general population. So in other words, if you had obese people who had surgery, lived longer, and had decreased mortality. Finally, benchmarking. Now, what I mean by benchmarking is the process of measuring the success of bariatric and metabolic surgery. It's the measure of outcomes from their surgery, and it's a quality assessments performed to identify the best possible outcomes by analyzing data from high-volume centers or nations. This is the role of the IFSO Global Registry, to identify core outcome measures, and the registry is in the process of identifying 5 or 6 outcome measures that can be reliably defined, measured, and compared internationally. And they're going to identify case ascertainment for each contributing national registry or country, and also allowing for differing levels of contribution to the registry. They also would like to strengthen the governance and auditing process such that all contributing societies are aware of the International Organization for Standardization requirements for de-identification. So the IFSO Global Registry would like to collect data that is reliable, prospectively collected, collated, and analyzed to provide us with a unique opportunity to better understand patterns of disease and the effect of treatments or intervention, and with a vision to provide the most credible and transparent information available for bariatric and metabolic surgery. So, ladies and gentlemen, I believe that in the next decade for bariatric surgery has undergone amazing changes since its inception and will continue to evolve. The operative procedures from open surgeries to laparoscopic and minimal access surgeries will progress further and will include endoscopic and robotic approaches. I believe our operative approach will continue to become safer and more efficacious. The pathophysiology of obesity, the associated comorbid medical conditions, the mechanisms of action of different surgical approaches will be better understood. And through the IFSO Global Registry data that is reliable, prospectively collected, collated, and analyzed, will provide us with a unique opportunity to understand obesity as a disease and to be able to offer effective treatments. Once again, thank you very much for the opportunity.
Thank you, Lilian. Could I ask all the audience to send their questions on the chat box to Sanjay or Chetan, who will forward them to the team. Thank you, Lilian, for a wonderful talk. Could I just start with the first question? It's great that we have this meeting today virtually. With the third wave looming in major parts of Europe, with several countries shut down, I think we have to be a bit more optimistic about the numbers for 2022. It looks as though 2022 may be a difficult year, although better than 2021. So what do you think about that, Lilian?
Yes, I am concerned with the new wave that's coming through Europe and of course the Northern Hemisphere with your winter coming. We are also in the Southern Hemisphere in Australia opening up our borders, not only interstate, also to the international people for the first time in 18 months. I think we have to be optimistic because vaccination is now available compared to 18 months ago. And we also have some new antiviral therapies coming. So I think the disease of COVID-19 may be different from what we have seen previously. It could be numbers are increasing, but they are certainly not as severe as it was last year.
Thank you. Any of the chairman, please.
We have a question from Irene. We have a question from Irene. Why was there a decrease in the gastric band? And Did it have anything to do with its effectiveness, Lilian? That's a question from the audience, from Irene.
So with my experience of gastric band, it requires a lot of work on the team looking after the patient. We know that in the first year of gastric banding, you almost have to see the patient 4 to 6 weekly for effective adjustments and effective weight loss. That practice is changing. Many new, younger surgeons are not prepared to spend that time with the patients. And I think lifestyles of patients also are changing. They don't want to come back for regular adjustments. They want an operation where they can then go and live their life and not be tied to the clinic as much. Whether that's a good thing, I'm not sure, but I think that is driving the popularity of the gastric band down.
Thank you.
Thank you.
David.
David wants to.
Yeah, I have a question for Peter and for Rishi. So when we looked at both of your presentations, the sort of Geneva study and then the BOMS MBSR registry, trying to get a feel for how safe it really was to restart bariatric surgery during the pandemic. We're getting two slightly different pictures, so maybe look at the same thing from a different angle. But my question to you both was, with the benefit of hindsight, which is always a lot easier, do you think we got it right, the way we reacted and the way we restarted?
First, whom do you want to go first, Peter?
Right. Yes, the National Registry, the UK National Registry, we know suffers from follow-up of patients after discharge. So the data that we've got there is very, you can rely on that for the in-hospital problems. I'm not so sure about the post-discharge. I was studying Rishi's slide very, very closely, looking for his pink spots and the UK numbers. And there was only one case in the UK that had a COVID infection. So I suspect that might have happened outside. But broadly, we were showing that bariatric surgery is safe if you've screened the person and that you have help them keep isolated prior to surgery and get them in and out of surgery fast. So the short answer, David, is yes, I think we did get it right.
Rishi?
I also agree with Peter. I think I did not present my COBRA study in which we looked at the stoppage of bariatric surgery, and there was a period of time when no bariatric surgery was being performed, and we've published that. So we know that. But when bariatric surgeons restarted, clearly we were doing something right, that the patients were not dying or having COVID, or the ones who were actually contracting COVID were not being reported. That is possible. But from what the data we have, it seems that precautions were being followed, and that was in Geneva 1. So Geneva 1 found that if you took preoperative precautions, it improves outcomes. But Geneva 2 found that if you are actually operating during lull, during the period when there is reduced COVID incidence, that is the time when there is reduced incidence of post-operative COVID infections.
Rishi, a question to you. I mean, it's a fantastic study, your paper on Geneva study, or the fantastic results in it. What is the single most factor? Because we are likely to see the third wave hitting Europe, around the world, more so, as Lilian said, the northern and possibly southern hemisphere, with the gates being opened up. What will be one or two important salient points or advice you would tell from your study to all the audience?
If I assimilate the data, and this is not, we did not get a statistical significance in Geneva 2, although we did get it in 1, I would still say a short period of our self-isolation followed by RT-PCR followed by a small period of self-isolation. In Geneva 1, we got statistical significance for it. In Geneva 2, we did not. But Geneva 2 was conducted at a time when the worldwide incidence was dropping. And that is why the incidence wasn't as high, and we couldn't calculate that. So it is not completely evidence-based, but from looking at all the evidence across the different COVID and surgical papers, it seems that RT-PCR followed by a short period of self-isolation in medium to intermediate or to high-risk surgery is the right thing to do.
Thank you.
Question to everyone. Do we think this pandemic and the shutting down of bariatric surgery and Rishi's information that we should get patients in and out of hospital as quickly as possible with short operating times. Is this going to push back robotic surgery and for bariatrics? Is it going to push back the development of technologies? And how do we deal with that at a time when people are starting to learn robotics and take a little longer? David.
I think that it is an important point, actually, because I mean, and it brings us on to this whole question about prioritization of bariatric surgery and who you prioritize. You know, are you going to do cases that are going to take a lot longer in theatre, maybe doing a robotic operation? And looking at Rishi's data, you know, the people who were doing badly were the type 2 diabetics, the patients, you know, who were hypertensive, sleep apnea. You know, does that mean they're the people we ought to be prioritizing because they're the sickest, which was actually the consensus statement, I think, that came out with Francesco Rubino originally? Or do we think actually these are the people most likely to do badly? So in fact, maybe although they're the sickest, they're the people we should be leaving at home, because if we bring them in, we're more likely to do some harm. And I'd be interested to know what the rest of the panel think about this, because it was one of the sort of early consensus statements was that we really ought to be bringing in these very sick, the diabetics, people on transplant waiting lists. These were the people we should be concentrating on. But in fact, when you look at the data from Geneva, actually, would we be doing more harm by doing that? I'd be interested to know Lilian's view on that.
Lilian, can you come in, please?
Yes, I think that's a very good question. We are in a different wave of pandemic now. I think at the beginning, we were very anxious for our patients, and particularly we know that patients with diabetes, with obesity, were at higher risk of doing badly with COVID. Today, we know that, you know, they still do not as well, but maybe we should help them with their comorbidities, help them their obesity, their weight problem, and get them in a better position to cope with further infections. So I think it really depends on where your country is with the wave, how your hospital is set to deal with the incoming influx of patients, you know, on your pandemic curve.
Thank you, Lilian. David, that question is really like the old saying, to be or not to be. It's a tricky one from you, because I think in the initial COVID pandemic, we did not know anything, fair enough, but we came through the international guidelines where we have agreed to do these patients with P2s and P3s, they were classified in P3s. However, now with the entire, most of the European majority part of the world having had the vaccination, and in UK we're getting the third dose already done, or at least a large number had a third dose, it may be that we should stick to the original plan of P3s, that is the diabetic, the people being done now. Yes, you're right in asking the very genuine question. Initially, when we don't have the vaccine, we had a problem. That's a difficult dilemma for all of us. But with the vaccination kicked in and knowing that post-vaccination, the deaths are low, the problems are less, maybe it's time to pick up and do these people. That's my personal opinion. Thank you.
Chandra, could I come in just to try to answer John's question about technology and robotics in these difficult times? And I would, you know, I think we should always be supportive of new technology, innovative technology, and robotics. But I would look at what's happened to training worldwide, certainly in the UK, and I'm sure that is reflective of practice around the world. Training's really suffered and it's been decimated across all aspects, all disciplines of medicine, particularly surgery, which is craft-based. And I think what we should try to do is that there are several processes that we have put in place for as part of COVID restoration, like what Rishi's mentioned about isolation, about green pathways. So we should not lose that advantage, but we should still continue to soldier on, but look after our trainees, look after the training in general. So I think robotics is great. I personally do robotic surgery, but if I cannot take my trainee through a standard laparoscopic Nissen fundoplication because of pressures on waiting lists and kind of thing, what is the purpose of, you know, spending more time on robots? I think we should still continue to work on the console and continue to keep our skills up to date, but get the whole system around us to a basic level before we really push on that. That's my personal view.
Thank you. One of the views of several experts who speak around to the world is that this pandemic is going to last throughout 22 in a small way, up or down, and it's not until 2023 that we are going to be out of this woods. What do you think? What does Lilian think? What does David think? Or Peter Small, please I would like your views.
You're asking whether we're going to get out of this pandemic in 2022,
Yeah.
2023. I just have to be optimistic. I hope we do. You know, I think everyone's working to get this pandemic under control, getting this disease under control. And I just have to be optimistic.
The reason I asked that question is yesterday there was this huge furor about this Botswana variant, which is resistant to any of the vaccinations that's going around. And the Delta variant has hit Europe big time now. Austria has shut down, part of Germany, part of Belgium has stopped operating. So that's the concern I raised. And what do the others think, guys? 2023 is the first time returning normal.
Yeah, I mean, the government have done some predictions, haven't they? And they've done a kind of optimistic prediction and a less optimistic prediction. And I think the optimistic one is the disease will become endemic and something we can all live with during early 2023. And the less optimistic one is it might take till 2025 before that occurs. I'm no virologist, but my understanding, I'm sure we've all done lots of reading on this, is the natural history of these viruses is as they mutate, they do tend to become less severe in terms of the clinical illness that they produce. They may still be highly infectious, but and so let's just hope and pray that is the case. It's a really difficult question to answer, Chandra, but like Lilian, I really hope it is, next year, if it could be.
Thank you, David. Actually, that's a very thoughtful answer. One of the things which we hear is that in UK, we already have most of the medical workforce had the third jab already, third dose booster. And there's a talk about the fourth dose in autumn. So watch out, guys. Anybody else ask any questions or any of the comments, please?
I think it's really important that we finish on a positive note and hope for the future as well. I think what gives us as bariatric surgeons strength to continue what we're doing is that obesity was one of the, if not the biggest factor in a bad outcome for patients who get COVID. So we need to tackle obesity on whatever front, whether it's through surgical methods or through medical methods. And if we do that, I think we've got good argument to continue what we do.
Thank you. I thank all the speakers, my co-chairman, David Kerrigan, John Loy, Will Hawkins, and the speakers, Mr. Vinod Menon, Prof. Lilian Kow, and Rishi Singhal and Peter Small. Thank you all for the wonderful session, and thank Sanjay for putting up a beautiful session, which is absolutely phenomenal. Thank you very much.
Can I just add, thanks, Chandra. Can we just add that we have been told that there were at least 320 delegates watching live worldwide as the session went on throughout the whole last 2 hours and a half. So this is fantastic. Thank you, everybody.
Thank you,
everyone.
Thank you.
See you, Lilian. Joy.
We will see you in 10 minutes time.